Welcome to the Egg Whisperer Show, a podcast exclusively designed to create more reproductive health awareness and discuss your fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
Hi, everyone. Welcome to the Egg Whisperer Show. I'm so excited to have Dr. John Norian on today's show. Hi, John.
Hey, guys. Great to see you. Amy, Dr. Amy, thank you so much for having me.
If you call me Dr. Amy, no show for you. I love hanging out with you. I wish we lived closer. I just want to tell our audience a little bit about you. And certainly I want you to share with us too about yourself. But John is with HRC Fertility and you have an office in Pasadena now, right?
I do. Pasadena and then a bedroom community in Rancho Cucamonga.
Nice. Why do they call it a bedroom community? Because it's kind of popping there in Rancho Cucamonga.
It is. There's a lot going on. We're right near the Ontario airport, an international airport.
Yeah, I love that airport. I went to UC Riverside, so that was one of the closest airports. And when they remodeled it, it was fabulous for everybody. So you do everything related to fertility, just like me. You're board certified in OBGYN and reproductive endocrinology, and you went to UC Berkeley with a medical degree from the Royal College of Surgeons, and you finished your residency at Albert Einstein College of Medicine in New York and your fellowship at the NIH. Not too shabby. Very, very impressive. And not only that, you were a lieutenant commander, that's very funny for me to say, in the U.S. Public Health Service. And you've had the privilege of providing care to military families. So welcome to the show. Thank you so much. And we're going to get to the meat of this, which is challenging IVF cases and what can we do? So John, did I leave anything out that you want to share with our audience about yourself?
No, you hit all the main points. I'm a real advocate for all people struggling with fertility, whether you have male parts, female parts, whether you're single in a same-sex relationship or just sort of walking the walk of fertility. It's so nice to be chatting about it. Thank you.
You're welcome. So you're a baby maker for anyone who wants a baby. Okay. First IVF challenge I want to talk through. So you're doing an egg retrieval or you have a patient who presents this case to you from like as a second opinion consult and there are no eggs at the time of egg retrieval. What do you think about? What is the process that you go through?
Right. So no eggs at retrieval. Sometimes as a reproductive specialist, we have a little bit of an idea if they're going to be a low responder, medium responder, high responder. Of course we do, because we're monitoring the follicles. We're seeing how they're growing and developing. So if I have a woman who has, let's say, 15 follicles and I get no eggs, that's totally different than a woman who has, let's say, 1 or 2 follicles and gets no eggs. But let's go with the 15 because that's super rare. And so what would I do? Number one, I would be bummed. I would be disappointed. Let's just call a spade because I'm so particular at retrieval. Like when I'm doing a retrieval, I'm doing little techniques to try to release the egg from that follicle. So one, you might have seen me spin my fingers. We're doing different techniques to help with the egg yield, number one. Number two is in the PACU, in the post-anesthesia care unit, I would check an HCG, a blood level, an HCG and a progesterone level, because I want to see, was there an issue with the trigger? Like by chance, did I use an HCG trigger, like a full 10,000 units? Or did I use a Lupron trigger, which is a GnRH? It's, we need more tea or coffee to talk about that. But I'd want to know the type of trigger and then check a level to see, did she take her medications correctly and that sort of thing. So those are sort of like 2 starting points right there.
So could be a medication issue. What else?
It could be a medication issue. Now, other things, it's a really rare situation. And by the way, the group at the NIH and other groups around the US have published on this, where it's called an empty follicle syndrome. And it's super, super rare. Believe it or not, in research studies, well done studies, they've looked at it, and 2/3 of the time, there's a medication issue. So about 1/3 of the time, though, people have rare situations where the egg just doesn't release from the follicle. So what are reasons for that? Or what are ways we can fix it? I guess that's maybe a 2-part, but it gets into really complicated, delicate steroid biology. So we're talking about things like the cyclooxygenase pathway. We're talking about different like apoptotic pathways. Like is the collagen breaking down from the follicles? Are we going through the proper hormonal steps to allow that egg to release?
Yeah. And then what about if the patient actually has ovulated? Is that something that you could actually see when you're doing the egg retrieval, if that's the reason why they have no egg?
You can. And that's, of course, a huge reason. And that's rare, but it can happen, especially in women who are low responders, because sometimes they break through, especially if we're using an antagonist cycle, where their own body's FSH and LH are really just high. That's who they are, right? They have diminished ovarian reserve. And sometimes they break through the antagonist, the ganirelix or the cetrotide that we use. So what we would see is you see fluid around the ovary or fluid in the cul-de-sac. Isn't that so funny? Like human anatomy, there's a part of the body called the cul-de-sac. I'm like, that was the end of that bedroom community street.
I agree. It is funny that we call it that. So what kind of things do you do? So if someone's ovulated, what would you do next time?
Yeah. So what would I do next? So depends on the reason, of course, right? So if she broke through, I would probably use a different protocol. I would be monitoring her maybe that bit more closely. Usually I see people at the end of a cycle every other day, but maybe I would start monitoring every day, and I would be monitoring LH levels. And maybe I would give an antagonist on the morning if I was doing an antagonist cycle of the trigger shot. So there's some other little things that we would do, but I might even use a Lupron cycle, a long Lupron cycle, as a way to better prevent ovulation if that were the cause.
Yeah, I mean, I agree. It's kind of like if your pants are falling off, you want to wear a belt and suspenders. So sometimes you can just use Lupron and the antagonist, use a whole bunch of the antagonists for people who do that to you. I've seen it before. Those are some really challenging cases.
I have, one other thing that sometimes as far as the trigger goes, and actually this data came from the UCSF period where they're talking about their endpoint actually, to be fair, Amy, wasn't egg yield, egg number, but I think it was egg maturity. But it gets into this when you do like a co-trigger. So when you trigger not just with HCG, but you trigger with FSH. So when I trigger, I would for sure give a 10K HCG trigger. I might even do a 20K. A couple of my partners do that. And then also give it with a good bolus of follicle stimulating hormone. Because naturally, the way the human body works is it's not just an LH surge, guys. It's also an LH with a little bit of FSH surge. So the idea of trying to do that LH, aka HCG, with a little bit of follicle gone left may be a little bit of benefit. So there you go, belt and suspenders.
Exactly. And I do that too. I sometimes add 300 or 600 IUs of gonal or, FSH based on that exact same study that you just shared with us. So it's like we're the same person. We should be in the same city.
I know. Come on, move down, Lynn.
No, seriously. Okay, so the next challenge.
I missed Berkeley though. That the scones and the lattes are so much better up.
Right. What year did you graduate? I forgot.
Oh, geez, I don't want to date myself. Let's say early 90s. Think Pearl Jam.
Okay, no. I mean, we're not that. We're basically the same age, so we might have been there at the same time. Okay, so next is mature eggs, and you brought it up. Like, what if you do an egg retrieval and you get, let's say, a certain number of eggs, let's say 5 eggs, and none are mature? That's a challenge. What would you do next?
Right. So a couple of things. Number one is, of course, you got to sit down. You got to go through the protocol with like a fine tooth comb. And what I typically do is I'll push another day, right? A lot of times we'll be like, okay, if I triggered you on day 10 and your follicles were in that OG perfect spot, I'm going to close my eyes and I'm going to go one more day the next time. And even though I historically have done well with triggering when I've got 3 follicles, 18 millimeters or greater, by the way, I measure in 2 dimensions, not just 1 dimension, then I might, for this unique patient, trigger at a 20 or trigger at a 22 as a way to help push egg maturity. The other thing is it gets to that HCG. So I would definitely, depends on her diagnosis, because if she's like a hardcore PCO patient or a hardcore hypothalamic, remember guys, I've taken care of people who are super fit, right? Like I was an old military doctor. So, people who've gone to Hawaii, like Ironman, Iron Women athletes, and infertility is not a time to be bone rail thin. Like we need healthy fats. And when you're super lean or hypothalamic, And that may be a food issue or it may just be a biology issue. And again, we need some Pete's Coffee to talk about that. But then I would never trigger with Lupron. I would trigger with HCG because they need that LH. But that may also help push the egg maturity thing. So those are some tools that I use. We also just talked about that FSH thing.
Right. I agree. I do the same thing. Okay. So now you have mature eggs and no fertilization. What do you think about when you have that challenge in front of you?
Right. And that's always really upsetting. That's a tough call. And back in the old days of IVF, when we didn't have ICSI, right? ICSI it's been around for a while. It was developed in the 90s in Paris, and then the Americans really optimized the technique. So a few things is I'd want to look at the fertilization method, because if we're doing ICSI, remember that's when we get the best sperm, we inseminate it directly into the egg, just a single sperm. We learn about the egg. Right? We learn about the membrane of the egg. We learn, is the egg dark or granular? Are there a lot of inclusion bodies or a lot of oxidative stress, I guess you might say? Because we're trying to get a sense, is this more of an egg issue, no fer, or is this more of a sperm issue for no fertilization? So sometimes ICSI helps us that way. Other things is sort of going back to the future, which is sort of a funny concept we've used in our laboratory at HRC Fertility in Pasadena, is like an old calcium ionophore where we can put calcium, what if it's calcium? Calcium is like a 2 positive ions. I know everyone's like, it's for your bones. But what it is these like 2 positive ions, and putting that, it changes the electrical membrane of the egg slightly. And then arguably it may help the sperm sort of better get in. And one of the cool things biologically, I know this is a tangent, Amy, I'm sorry, but whoever designed this as humans, it is awesome because we biologically, once the sperm hits, even naturally, right? One sperm fertilizes the egg, then there's a huge electrical cascade of ions. So huge, that kick all the other sperm out from around the egg. So this idea of sort of loosening up the zona pellucida, or the shell of the egg, may help a little bit with fertilization. So anyways, those are some thoughts. I'm not sure. Do you have other ideas as well?
No, I'm right there with you. That's exactly what I would do too. See about ICSI, Pixie. There's different things you can do. If you did ICSI, Pixie, then do calcium ionophore. I'm right there with you.
Yeah, Pixie, I think Pixie regionally, I'm glad you brought this up, is a little more of a Bay Area, because, and I've traveled, I've worked in, I did my residency in New York, so I know the fertility guys there, and I did my fellowship in DC, and then now I'm in Los Angeles. It's weird how healthcare gets a little bit regional, and Pixie, that's where you sort of grow the sperm on a membrane, on a gel, and then you sort of pick it out, and ideally you're picking the best sperm that's going to be the super sperm that can fertilize it. My understanding is it's only somewhat effective. I think people believe in it a little more than others. I don't know.
Yeah. I mean, I don't think that it's going to be a superhero for every case, but when my patients and most of my patients are over the age of 39. So we're so lucky to even get one egg. And I'm like, I got to make sure I pick that winner sperm with the little superhero cap on the back on it. Yeah. Okay. So then how about no sperm on the day of egg retrieval?
So that's a great question. So I've been in this situation before. Some of it's a little more anticipated, and other times it's not. Honestly, just a personal story. I was taking care of a wonderful couple, and the gentleman went to his primary care doctor, who was like, my wife's going through fertility. I'm feeling a little sluggish, a little slow. And the primary care doctor, well-meaning, was like, oh, why don't you just take a little bit of testosterone? So he was, and he didn't share it with me, right? He just didn't mention it to me. And he was on testosterone for a couple months while his wife was getting ready to go through egg retrieval. We go to sperm retrieval. Their semen analysis beforehand was great. And ejaculates, no sperm, nada. Next time we're like, oh, sir, maybe it was just a bad thing. We didn't anticipate it. I looked at the sperm analysis again. And he could ejaculate twice on the same day. And he did it. And no sperm again. So what do? We froze eggs. And thank God we live now. Then we talked to him more. We're like, hey, what's going on? and he took testosterone. So that just shut his sperm production down. So anyways, there's a happy story at the end is that he stopped testosterone. We got him on some vitamins. I think he took some Clomid. And they actually had two children because he ultimately reproduced sperm, which is great.
Right.
But, so that's like the unexpected. Sometimes also, we can also force retrieve sperm. So I myself am trained to do basic sperm retrievals, like a PESA, or percutaneous epididymal sperm aspiration, or just like a testicular biopsy. But in other situations, you really want to know, like, what's the cause for no sperm and that sort of thing. It is super rare to have an unexpected no sperm. One thing also I've had, which is really nerve-wracking, is when one of my male patients just can't produce a specimen, right? It's not that he doesn't have sperm, but he's just like, the ring. I mean, the room's hectic for a lot of guys, right? I know we make light of it, but most men don't interact with healthcare until we ask them to do the most private, intimate, right? And that private, intimate act is in like a medical room with dirty magazines and things, or dirty videos, no magazines anymore because of the pandemic. So that's the situation. Sometimes we give what we call emergent Viagra as a way to maybe we can, help the production of an erection. It doesn't always work. Again, freeze eggs, come back on another day and go from there.
Yeah. I call this sperm emergencies, and there's no, I'm trying to make a joke, ambulance that comes to help with that. I wish that there was like a kiosk where you can go and
in our field, there's very few emergencies, right?
Right.
My emergencies are literally yesterday. I just saw a patient, young woman who new diagnosis of breast cancer. Hey, John, can you see her? Of course. Right. So we saw her within a day, and really nice person. We're going to be starting meds in just a couple of days. The other is the sperm emergency. And then rarely is a ruptured ectopic, but gosh, we know about those now. Ruptured ectopics are so rare.
Right. Okay.
Sorry, I digress. I'm chatting.
No, we love it. That's why you're here. Okay. So now we talked about sperm, but what about you have sperm, you've made embryos, but then no blastocyst. So there's no embryo progression and there's no blastocyst from the case. What would you think about? How would you help a couple or a person in that situation?
Yeah, I think that's a great question, and it comes up. And this is where when you're working on your fertility doc, you really need to powwow afterwards. And you need that 20-minute conversation, with the doctor. You got to get their insight. And really, it goes from the first time you met. That's what I do. We go through their pre-cycle testing labs. What's their AMH? What's their sperm analysis? Did you do a DNA fragmentation of the sperm? Things like that. Also, you go through the nitty-gritty of the embryology, and you try to get a sense, is this an egg issue or is this a sperm issue? I also want to know, where did the embryo stop developing, right? Because in our literature, there's a thing called, let's say, a day 3 arrest, right? And what's a day 3 arrest? So day 3 is you go from day 1, where it's a fertilized egg. Day 2, there's typically 2 cells, 4 cells. Day 3, 6, 7, 8, 9 cells. And then the embryo does this crazy thing where it comes a blob, like a morula, a compacting cell. And then it goes through this beautiful, remarkable chariots of fire sort of music in the background, embryonic expansion. And if you stop at that day 3, the old historical thought was the egg is sort of the boss, by the way, from day 1 to day 3. And the egg is sort of always the boss, but that's another thing. But the egg is the boss because the size of the embryo is the size of the egg on day 1, day 2, day 3, right? And you just get different cells within that egg shell, I guess you would say. And then the shell sort of morphs and it becomes a glob and expands. So when you have a day 3 arrest, people think historically that it's more of a sperm issue, because that's when you need the sperm genome to really activate and go through this expansion process. But my understanding of the literature is there's a growing body of evidence is that the egg quality also plays a big role. So this idea of the mitochondria of the egg, is it healthy, strong, fit mitochondria? Are the engines of the egg really good? And that's what the mitochondria is. So this idea, and a lot of this came out of Boston, some laboratories there, and then other groups around the world have looked about this, is can we improve egg quality by improving the engines of the egg? And the idea is that you get a lot of D3 arrest. You don't make it to blast. That was your question, where it may not just be a sperm issue, but there may be like an egg energy issue. So there you go. I know that's some thoughts that I have. And I sort of talk to people, then everyone always comes to me, and this is the hardest thing, Amy, is, hey, doctor, hey, John, hey, Dr. Norian, like, how can I improve egg quality? I have this like no conversion to blasting. What can I do? And it's hard. It's really hard. In the old days when they didn't know what the heck they were doing, but Jacques Cohen, a pioneer in our field, wonderful guy. I mean, this is like in the early 80s, and they took cytoplasm from a young donor egg and they put it into an egg of an older woman. I mean, it was shut down in a heartbeat. The federal government, the FDA, what the hell are you doing? 3-person embryos? This is like not allowed. And honestly, Jacques didn't know what he was doing. They didn't transfer this embryo. They were just learning. Guys, like in the 80s with IVF, we just didn't know. So what they saw, though, was really remarkable. Way to go, Dr. Cohen, right? Because what they saw is that quality from the cytoplasm young donor into that older person, really like they became good embryos. But you can't do that. And then we get into all this like CoQ10 of the world and all these like supplements and all this different things of trying to get that engine of the cell better, eat healthy, sleep, low inflammatory diet, all this stuff we talk about. I'm a huge wonk when it comes to nutrition, but realistically, it only takes us so far. Changing egg quality is difficult.
Right. I agree. Thank you for that. Okay. So now
Sorry, I'm talking too much. You need to talk more, Amy.
No, that's why I brought you on. Okay. So now we have blastocysts, but what if none of them have normal chromosomes? What do you do then?
Yeah. So then it's like, what's the age of the female? How many blastocysts did you have? Is this more of like a chance thing, right? Where we know that as women get older, the likelihood of having a chromosomally normal embryo does decline, right? So it may just be, I'm human, right? Or it may be, those are sort of the main things, or it may just be a numbers issue, right? Where if I just had more numbers, then I would have had a higher chance of having a chromosomally normal embryo, right? Because even, let's say, women under, what I tell people, when they're under 35, the likelihood of having a chromosomally normal blastocyst, the early studies suggested about 60 to 65% normal per embryo. I think that number is lower. I'd love your thoughts on that when we're using the better sequencing platforms that we're using now. I usually see it at about like 55% in the age. What do you think about that?
Yeah, I think it's anywhere between 35 and 45%. I say 50% is probably closer to like age 30.
Yeah, I think that's fair. Yeah, so it depends on the age of the woman. A woman who's older, right? A woman who's over, let's say 42, she's got a few blastocysts. The likelihood of normal per embryo is going to be about 15, maybe 20% per embryo. So it just may be a numbers thing. And remember, it's per embryo, guys. Like even if something that's 50%, like flipping a coin, it's 50% each time. It's not 50% overall. So that's that. The other thing, just to highlight your question a little bit, like, hey, what if there's no normal chromosomes? Occasionally, especially a couple who's had like recurrent miscarriages, I might even do a karyotype to just make sure there's not like a translocation. Now, like, what's a translocation? I probably should comment on that. So a translocation is where you have a little bit of one chromosome do a switcheroo with another chromosome. But that's where, let's say, part of the end of, let's say, chromosome 1 goes on the end of chromosome 4, and 4 goes on 1, and 1 goes on 4. And that person, if the break point was at the right spot, they can go live a nice, happy, productive life because they have all their genes, right? Remember, genes are different than chromosomes. The problem is when they go to reproduce, if you have a translocation, it can be difficult making normal embryos or balanced embryos. So not something I will say with the next generation sequencing that we're doing a lot with the PGT now. sometimes you do pick up translocations. It depends how big it is, where it is, things like that.
Yeah. Okay. So now we have normal blastocysts. See what I'm doing? And then you're transferring them, or you want to transfer into the uterus, but the lining is just not thick enough. How do you deal with that challenge?
Yeah. So thin linings, how do we deal with thin linings? Those are tricky and they affect a certain percentage of all of our patients. So number one is you want to talk to the patient, right? That's always huge, right? Has this person had procedures? Has she had a DNC? Did she have a delivery and then had an infection right after labor and had they couldn't remove the whole placenta and she had an infection? It's like, does she have scar tissue? Is there like a mechanical cause for having a thin lining? And if there is, then maybe repairing the uterus might help a little bit. So that's one thing. One other big thing is the question is not just thickness, but what's the pattern? Because I'm more of a pattern person. I'm not sure about yourself versus thickness person. So typically doctors like myself, yourself, we like the lining to be greater than 7.5 millimeters. Once you hit 8, I'm pretty happy. I think my sweet OG spot, excuse the term, but is between 9 and 14 millimeters. But is it triple line? Is it pretty darn close to triple line or like a mixed pattern? Because if it's a good pattern, I've even had a surrogate. Oh my gosh, this was hectic. It was like we had just opened up this office. I was working with a new group of, partners. I had a woman who needed a surrogate, and it ended up being her sister or friend or something like that. And it was a whole story. Anyways, I could not get her lining thicker than 6 millimeters, but it was gorgeously triple line. And again, I just closed my eyes, Dr. Hamey, and I looked at that pattern and I was like, I'm doing this. And it ended up being effective. But anyway, so it's not always the case. That's not always happen, because then doctors like us, we try to fix it, right? We try to thicken the lining. And what are some things that we do? Usually I use injectable cycles. I know it's a total pain and I'm sorry for that, but I just think the pharmacokinetics, like the absorption, the half-life of estrogen and progesterone is better if it's injectable. But sometimes using different routes of estrogen, people behave better with. Again, we need that cup of Pete's coffee to talk about why. But part of that is, and I wish I owned Pete's, by the way, not right, but I don't. But the reason for that is estrogen receptor DNA is highly conserved in humans. So we all have the same DNA for estrogen receptor. The deal is that upstream, downstream of that receptor are these enhancers, silencers, transcription factors, modifiers. And that's where sometimes the different route of estrogen may help thicken that lining a little bit better. And that's why certain women are like, even my sister included, is like, oh my God, John, I hate ortho-tricycline, but I love this other one, right? Or vice versa. Or like, oh, I'm totally an ortho-tricycline girl. For whatever reason, it's not because of the estrogen, because remember the estrogen receptor, they always have like estradiol, presumably erythritol estradiol, but it's how they fit on the receptor. So there you go. That was sort of a long answer, but different routes of estrogen, progesterone. Other things, sometimes I use pentoxyphyllene. That also can help improve blood flow to the lining. Believe it or not, Viagra, which is, there's some evidence there. It's not great evidence as a way to improve blood flow. Remember, forming an erection is a blood flow issue. It's not like this whole other thing. So it's just trying to improve blood flow to the endometrium.
Yeah, I agree. And then also some vitamins like vitamin E, L-arginine, I've seen help, adding aspirin. There's a study looking at HGH, for example, and I've also used hyperbaric oxygen therapy in patients with thin linings, and I've seen that help too. Okay, so now you have a beautiful lining, but there's a little bit of fluid in the lining. What would you do then?
So fluid in the lining. So the first steps, or it may not be too big a deal if it's a small amount of fluid. If it's 1 millimeter, your doctor may write it. May tell you some like basic things as a way to slightly help improve blood flow to the uterus and maybe help extrude the fluid and play along with me, Amy. It's actually something I don't love talking about even as a reproductive specialist, but So number one, I tell people do some jumping jacks. Just get that blood flowing through your body.
Shut
Move
up.
around,
You do
exercise.
not tell them to do jumping jacks.
Sorry.
Like literally, you tell them to do jumping jacks?
So I think improving blood flow through the body may help a little. There's very minimal evidence.
Hey, I will try that next time. Hey, man, that's why we had you on here to talk about these challenges. I want to hear what you do. This is a great.
Right. And then the other idea is, do you aspirate it, right? Do you just place a little thin little like piece of angel hair pasta, floppy little IUI catheter into the uterus and then just sort of gently remove it? Those are some things I've seen done.
Yeah.
Reproductively, I love working in my field. I love the biology. I love the steroids. I love this delicate interaction of these things that are at such low concentrations, right? Estradiol, it's like at picograms per milliliter, right? Some of our other, it's crazy. And then I give it my internal medicine doctor, and these things have such control on our body, right? But then I talk to my internal medicine doctors. They're like, oh, yeah, I'm regulating glucose. It's at like a milligram per deciliter. I'm like, I'm the one delegating with these tiny little substances, these hormones that have such profound effect. Anyway, sorry.
Okay, so what if you have a patient? So we'll move on from that because that's just too funny for me, and I love it. What if a woman cannot tolerate injection? What would you do for a patient like that? Like she can't tolerate looking at needles, giving herself needles. How would you manage that challenge?
Yeah. I've been in that situation. I'm sure you have as well. So number one, in order to retrieve eggs, we use these hormones that are very small peptides, right? So we just can't take FSH and LH. We can't take it orally because our stomach acids will just shred it apart. We just won't be able to stimulate the ovaries well. There are some other medications like Clomid or Letrozole, that oral medications that we get instead of like one dominant follicle, maybe we'll get 2 or 3. So this idea of doing these like mini stems, you just don't do as well. You just don't get as many eggs. They don't fertilize as well. You don't create as many embryos, but that's something. The other is going through an IVF cycle. Believe it or not, you're just doing these baby injections. Usually most people can do it. Sometimes we have injection nurses that can help the patient if she can't do it herself or have her spouse or family member do it. And those are some ways that we do it. Sometimes a little behavioral therapy can also help and that sort of thing.
And I bet there's this cool little thing. I don't know if you've heard of it, the Fuzzy Bee. It's this little device that can cool the skin down. It has a little gel pack and then it vibrates and then you don't even feel the needle. It's really a great solution for some patients.
Oh, that's cool. There's another one that we've used, Cinera, that's a topical pain numbing medicine that can work. And when you do the injection, it just doesn't hurt as much.
Yeah, go ahead.
I was just going to say the other injections, when we're doing the frozen embryo transfer cycle, I usually do program cycles. I've just found that I do better. I know there's a group of literature where you do these natural cycles, and I've played around with it and have done so, and of course read all the studies and whatnot. So what I tend to do is I use non-injectables. So we use oral medications, we use vaginal medications, patches. I just need my patient to be a little more on it, right? Like if I have a little bit of a spacey patient, and remember, sometimes doctors are the spaciest patients because they're all over the place. Injectables tend to just be more steady state absorption. But if you're on it and you're not going to miss your dose at 2 p.m, then you can maybe do the non-injectable ones.
I agree. I feel like the vaginal suppositories are just as good as the injectable. If you skip one, though, your efforts are done. And I don't think people realize how important it is to keep to the schedule. And in these studies that show that the injectables are better, I don't really believe that. I think in a certain patient population, vaginal oral administration of some of this stuff is just as good. So I'm glad you said that.
I'm a little bit of a whip. I'd love to ask you, when I use my progesterone, I use it usually twofold because I take care of humans, right? And we're not perfect. I usually give vaginal endometrium or vaginal progesterone suppository, and usually an oral because it's the belt and suspenders thing. But I know the study showed just straight vaginal is what was in theory.
Right. Okay, so let's say last challenge for you. You have an patient, I know, and she can't take hormones. She's so allergic, or she has a blood clotting history or something that makes her so she cannot take hormones. How would you handle that IVF challenge?
Okay, so not take hormones. So a lot of times I have patients who can't take birth control pills, right? Remember, we use birth control to help regulate, plan, synchronize the cycle. So those are where we do what we call a day 2 start. So we just do that. We can avoid birth control pills very easily. The other is, a lot of times I talk to the patients and tell them, I'm giving you natural hormones. I know that you go down to that, gem shop and they're telling you this is, natural estrogen, and they're putting in estradiol, estriol, and they're saying this is natural. Your doctor's not giving you natural hormones. I'm like, baloney, I'm giving you estradiol. I'm giving you what your body produces. Estriol is what you produced when you were a fetus before you came out of your mother's abdomen. But I really try to talk to my patients, make them understand what we're doing. We're just helping supplement the body of its own hormones. But otherwise, we can do natural cycles. I'm not a huge believer in natural IVF. I came through the DC programs. There's a group there, Dominion Fertility, that does a lot of this type of thing. And they'll talk to you about their pregnancy rates, but it's all pregnancy rates per transfer. It's not pregnancy rates per first time you saw the doctor, pregnancy rates per retrieval. I mean, people come to me, they want to get pregnant yesterday. So I don't want to waste a year and a half retrieving 1 egg, retrieving 0 eggs, retrieving 1 egg, retrieving 0 eggs, retrieving 1. That's what natural IVF is.
Right.
So, okay, your pregnancy rate per transfer is good, but you just wasted 2 years of your 41-year-old patient's life because you didn't do a good job communicating to her about the hormones that we use, or just the body's own pituitary hormones, or own estrogen or progesterone. So, I don't know. I think that's sort of my approach. I try not to use synthetic hormones, and especially if someone has a blood clot, then we really are hyper aware that we'll do a full thrombophilia panel. I'll try to really understand what's going on with their biology and that sort of thing.
Love it. Okay, John. Well, thank you for joining us today on our show about challenges and challenging IVF cases. You did such a great job communicating with us. I know that you are known to be a fabulous communicator. So your patients are so lucky to have you at HRC. So thank you for joining us today. Will you come back for a live Q&A soon?
I would love to. This is my maiden voice. This is my first time on Dr. Ely. I was today. Have a nice day. It's great. I love
That's
it.
right. That's me. Well, thank you, John. I appreciate you so much, and we'll see you soon. Okay. Thanks again.
Thank you so much for listening and making the Egg Whisperer Show a part of your weekly routine. To find show notes and a full transcript for this episode, visit dramy.org and look under the blog tab. While you're there, you can find a link for the Egg Whisperer newsletter, which keeps you in the know about fertility news. You can also find Dr. Amy and the Egg Whisperer Show on YouTube, Instagram, or Facebook. If you'd like to learn even more, Dr. Amy offers classes at the Egg Whisperer School, eggwhispererschool.com, or you can request a consultation on dramy.org. Thank you so much for tuning in and for sharing the Egg Whisperer Show with others. Keep sparkling and have a great day.